Hello, everybody. Welcome to Facebook Veterinary Neurology here. We are very pleased to introduce Dr. Ines Carrera. I'm still getting over the countdown. That was a very exciting countdown into this session. We are, yes, very pleased to have Ines here to go over a couple of cases that have been posted on the Facebook website and give us the answers to the challenges. Hopefully you've had some time to have a look at it. Briefly to introduce Ines, many of you already know her as kind of world-renowned neuroimager. She graduated from Spain and worked in small animal practice there, and then moved to Scotland because Spain was too hot. She wanted to go to Scotland, enjoy some snow in the summer, and she undertook a master's degree there at University of Glasgow. She felt very passionate about imaging, which was good because that's the way she decided to go. Finished her master's, started a residency in diagnostic imaging at the University of Glasgow. So obviously liked fried food a lot. No disrespect. Love fried food myself. And obtained a European diploma in veterinary diagnostic imaging in 2010. Seems like yesterday. She worked in several universities, Illinois in the USA, Sydney in Australia, Zurich in Switzerland for over 7 years, and then did a PhD in MR spectroscopy of the brain in dogs at the University of Bern and Zurich. Currently, she's working at Willow's Referral Centre and also for Vet Oracle Tele-imaging. So thank you very much, Ines. Really appreciate it. And I'm going to hand over to you. If there's any questions, I think Laurent's going to field those later. But thank you for giving us the answers on these case challenges.
Thank you very much. Thanks for the introduction. I don't know, many people know that I don't like fried food. But yes, I had some in Scotland. Let me just share this with you. So hello everybody, and I've seen the answers that many of you posted on these cases, and all of them were correct. So that's why I put again straight away the answers of these cases and empyema and abscess. And we're gonna go through these cases and discuss them. So the first case, it was an 11-month-old female English Cocker Spaniel, and I summarized here the same clinical history that we posted that day. And these were the images that we gave you. And now I'm gonna show you an entire video of the same transfer sequences, T2, T1, FLAIR with contrast, post-contrast, and T1 post-contrast. So we start from caudal to rostral, and you can see that this extraaxial subdural lesion is quite extensive and extends from the occipital lobe to the rostral lobe, and you can see that it's quite fairly homogeneous. Is hyper intense in T2, that is this one here. We see that now. Hyper intense in T2 is hypo to slightly iso-intense in T1. In FLAIR, the core is partially suppressed, but not completely. So this is the indication that is not pure CSF, that is something with different content as CSF of water. And then on the post-contrast, it's quite nice to see the meningeal enhancement, but also the splitting of the lines of the enhancement. You see that there are two different lines there, and the core of this lesion that is non-enhancing. And this is one of the hallmarks for empyemas, because it's encapsulated infection, so it has to have two walls, but because it's on the subdural space, it's got this crescent shape, and we characteristically see these two enhancing lines. You can see that it's causing quite a lot of mass effect, displacing the midline shift, or causing a midline shift. But if you notice, there is no much perilesional edema in this case. Now I'm going to show you the sagittal, and then we can see that the mass effect is quite prominent because it's causing also some transtentorial herniation and cerebellar herniation. So these are signs of really high intracranial pressure. The second one, so this is the summary of the MRI findings: subdural extraaxial crescent in shape space occupying lesion, hyperintense T2, not suppressing flare, and hypointense T1, moderate meningeal enhancement with the splitting of the contrast line, and moderate mass effect with midline shift, transtentorial, and cerebellar herniation. The next case, it was a 6-year-old domestic short hair, 1.5 months of history of apathy, weakness on the hind limbs, and altered mental status. And the neuroexam revealed severe tetraparesis and obnulation. And the previous history is that he fell from a 4th floor 5 months before presentation. So these are the images that we posted on Facebook. And now again, I'm going to show you the video of these transverse images, again from caudal to rostral. I'm going to allow you to just look at them. Because now we can see a few things more that we saw only on those transverse images that we posted. So I will play that again for you to look at. So it was this clear or quite obvious intraaxial lesion. I'm gonna just play the video myself. Quite well-defined, rounded intraaxial lesion in the around the piriform lobe, and with a hypo-intense rim in T2 and a hyper-intense center. In T1, it's quite nice to see that the rim of this lesion is slightly hyper-intense and is markedly enhancing with a very thick and slightly irregular ring enhancement. On flare, you see that it's not suppressed and is mostly hyper-intense, and it causes a moderate to severe mass effect and a very pronounced perilesional edema. All this hyper-intensity that we can see on the affecting the gray matter, that is iso-intense in T1, and it doesn't enhance after contrast. If you notice just next to this lesion, on the temporal bone, there is a fracture line. Yes, I'm gonna just stop there. No, let me see if I just gonna play it here, and then I'll stop. So this is a fracture line. So there is a scalp fracture, and also you can see some enhancement and hyperintensity and swelling around the muscles around the temporal bone and temporomandibular joint. If we continue at this level also, we can see that there is some meningeal enhancement, but there is no yet at this point the splitting that we saw before. But if we see that more rostrally, we do see that the splitting. So there is meningitis and also an empyema. So in this case, we have an intracranial abscess, and empyema, and meningitis. In the other case, we only saw empyema. Always remember to look at the lymph nodes, and in this case, we can see that the retropharyngeal lymph nodes are quite enlarged. So let me just stop it here. So these are the retropharyngeal lymph nodes. They are quite enlarged, and the mandibular lymph nodes are also quite pronounced. So these are the summary of the MRI findings. Well-defined intraaxial space-occupying lesion, hypointensity 2, hyperintensity 1, and contrast-enhanced rim, with a hyperintensity 2 center, hypointensity 1, and not enhancing. Moderate perilesional edema and mass effect, and also fracture of the skull, that is consistent with the trauma that they had before, enhancement of the surrounding muscles, meningitis, empyema, and lymphadenopathy. So the diagnoses are, as we said before, in the case 1 is subdural empyema, and the case 2 is brain abscess, but also with empyema and meningitis. So just to remember a tiny bit of the anatomy, and then we'll go through the pathophysiology and the causes of empyemas and abscesses, and also the differential diagnosis that we can have. So as you all know, the brain is surrounded by 3 layers of meninges, the dura, the arachnoid, and the pia. And in the brain, the dura and the arachnoid are joined only along the falx cerebri rostrally and the tentorium of the cerebellum caudally. But elsewhere, the dura and the arachnoid are held against each other. So there is a potential space for infection that can quite rapidly spread around it, like in the first case that we saw, quite extensive from the frontal lobe to the occipital lobe. Why we call it's an infection, and it's an encapsulated infection. So why we call one empyema and then abscess? So it's just a different terminology. Empyema is a collection or gathering of pus within a natural existing anatomical cavity. So, for example, also in the pleural space, is called an empyema. That's why in the subdural space, because it's a cavity, because the arachnoid and the pia are not held together, so then we call it empyema. But an abscess is a collection of pus in a newly formed cavity. So there are no cavities within the brain, so therefore an infection there is called an abscess. And if we put the example of the thorax, for example, in the lungs, this will be also an abscess. So the causes are, the most common are contiguous infection from adjacent structures, for example, infection in the middle ear and then inner ear, or direct access of bites, trauma, or surgery. But it can also be hematogenous from a distant infection somewhere else in the body, or very rare, but it's possible, a migration of a foreign body. And how they get there, overall, when it's a contiguous infection and it's the organisms spread through thrombophlebitis of the emissary veins. But when there is a direct access because of bite or trauma, when there is also myositis and infection of the bone, the organisms may spread inward through the Harvesian channels in bone. it's quite important to remember that empyema can occur months after trauma or bite injury, like in the first case that we saw. Excuse me, the second case that we saw. So it's quite important to investigate the previous clinical history because it may be because of something that happened many months ago. And it's been reported that dogs and cats with arteriovenous malformation or cardiac defects may be predisposed to brain abscesses. So the treatment, don't ask me, please. Then we have Laurent and Simon that can answer way much better than me. But empyemas and brain abscesses are a neurological emergency, and they need to be treated as soon as possible. In many instances, it requires surgery. But and or treated with antibiotics. The agents reported are most commonly bacteria, and these are all the species that have been reported, and occasional also fungal disease. Not to remember that the pathogenesis of the brain abscesses. When they, in the very first stage of the infection, is called the early cerebritis, that is 1 to 3 days. And in this stage, we see a lesion that is hyperintense in T2 and flare, hypointense in T1, and it barely has any contrast enhancement. So it doesn't have a wall yet, so we are not going to see a proper or the typical aspect of an appearance of an abscess like we saw in the case 2. So we need to remember this because it's quite important depending on the clinical history and the onset of the clinical signs. The late cerebritis is when from 4 to 9 days, and there is an early development of a necrotic center. So we may see already on the MRI a thin rim, may or not, maybe enhanced, but then definitely after 2 weeks, there is the early and late capsule stage, and is when we have the typical appearance of an abscess with a thick and slightly irregular rim enhancement. It is known in people, but I haven't found any reports in dogs, or that the capsule of the abscess is thicker on the cortical surface than on the ventricular side. So if an abscess is quite close to the ventricular system, it may also cause ventriculitis, and when there is ventriculitis, there is a quite high rate of mortality. So here, now I want to show you a case of an early cerebritis. So this is a dog. So first of all, I'm playing also from caudal to rostral, and we have the T2 on the top, this one, T2, T1 post-contrast, T1 pre-contrast, and this is flare without contrast. So we play it again. And first, this is a dog that had vestibular signs and for quite a while. And in the last 4 days, I started having seizures. So if you look first at the, I'm going to play it myself to be slower. And so first we look at the middle ear. So we see that both tympanic bulla are filled with very heterogeneous material, which is more hyperintense in T1 on the left side. It's not suppressed on flare. And it's slightly hyper to hypointense in T1. And we see that it's got a quite clear rim enhancement or peripheral enhancement on the right side. Also, excuse me, on the left, also on the right side slightly. If you now look at the soft tissues surrounding the tympanic bulla, you can see, let me stop it here. We can see that there is an asymmetry here. It's better. Here we see that also on the T2 that is hyper intense, and also on the flare, and we can see that it's enhancing after contrast. So the soft tissue surrounding the tympanic bulla, and also if you notice now around the temporal bone, they are enhancing. So now if we look inside the brain, in the intracranial cavity, the cranial cavity, we see that there is a ill-defined space-occupying lesion, intraaxial, affecting the most ventral aspect of the occipital lobe. And you see that this hyper-intense, quite homogeneous, hyper-intense in T2, slightly hypo, but no suppressed in flare, is hypo-intense in T1, and it barely have any contrast enhancement. If we look carefully, you see that there is a continuation here through the inner ear and mild meningeal enhancement. And this is the area where there is a communication between the middle ear with the inner ear and the intracranial structures. And this is what is causing potentially this early cerebritis. So here I have the frozen images. The blue arrows, I highlight the soft tissues enhancing, which confirms, this is a sign that is confirming us that there is an infection, because sometimes overall in small breed dogs, that is very common to have what people call the glue ear or primary otitis, secretory otitis. So this accumulation of material within the tympanic bulla that doesn't cause any clinical signs. The signal intensity is quite variable, and it's quite difficult sometimes to differentiate from infectious otitis. But definitely, if we have enhancement around the soft tissues, there is no doubt that there is going to be an infectious otitis. And here again, I highlight the meningeal enhancement and the area of hyperintensity that is representing an early cerebritis. So what are the differentials for an abscess and for an empyema? For an abscess, and now I'm going to refer to an encapsulated abscess. The main differential is a necrotic neoplasia. Hematoma in some sequences, for example, on the T2, it may look like an abscess because it may have a complete hypo-intense rim, but it just doesn't fit in the other signal intensity, in the other sequences. The signal intensity is just completely different because it's going to have signal void. And an abscess, it doesn't have a signal void. So then we can completely rule it out. So the main differential of an abscess is a necrotic neoplasia. And in an empyema, we are going to see some examples, and I'm going to explain that it may be a differential, a subdural hemorrhage or a cystic meningioma, but they are quite different. But I'm going to put some examples to have a more clear idea. So there is one sequence that is going to help us quite a lot to differentiate necrotic neoplasias from abscesses. And this is the diffusion and the ADC map. All abscesses, they have the rim, the capsule, is not restrictive, while the necrotic center, it is restrictive. It doesn't have any diffusion. So this means that is in the ADC map. So in the diffusion, it's going to be hyperintense, but on the ADC map, the rim is going to be hyperintense, exactly the same as the enhancement, but the center is going to be hypointense, it's going to be restrictive. And this happens with all abscesses, all mature abscesses. In neoplasias, the ADC tends to be the opposite. The center is hyperintense in ADC. And this is because it's still it's a necrosis as well, which is inside the tumor, but it's still having a lot of neovascularization, and part of the solid portion of the tumor is still within that core. So it's quite often is hyperintense in ADC, so not restrictive. However, this is not pathognomonic in neoplasias, and there are some neoplasias like this one that I show you that is got a rim enhancement, but on the ADC is not that hypointense. It's not that hyperintense. It's not completely hypointense, but we will have some maybe depths. Maybe in this case, we also we will depth a bit on the other sequences, like if we see the T2 it doesn't have that much nicely defined wall, but I just wanted to show you this is the best one that I had with a non-restrictive ADC, but I just wanted to highlight that this is pathognomonic, the signal intensity on the ADC for abscesses, but it is not for neoplasias. But it can help us quite a lot. The other sequence this is definitely pathognomonic, but I'm not going to explain a lot here, is spectroscopy. And spectroscopy can even tell us if it's an anaerobic abscess or is an aerobic abscess. So in cases where surgery is not an option, overall in people, because it is used in people more than in veterinary medicine, sadly, they can start the appropriate treatment with that. So this is, if you are more interested, you can ask me, or we can give another talk on another point, but here I put you the reference of this case report that is a goat that they had an anaerobic abscess proven. So what are the differentials for empyema? So other lesions that can look, that are subdural, it can be a hematoma. This can be because of a trauma, and then we could have clear evidence of skull fractures, and then we will differentiate if it's infected or not because of the enhancement. Other cases like this one is a chronic subdural hematoma in a dog with a I'm sorry, I cannot say that. Lipofuscinosis, the neurodegenerative disease. This is different from empyema. You see the nice enhancement of the meninges and dura, but there is no this nice splitting of the lines that we saw on the abscess. It's just mainly in the outer layer. And this will then be suppressing flare either. And even if it's a chronic hemorrhage, I think the level of oxygenation in the subdural space is not it's not the same as in the brain. And in these cases, at least the ones I've seen, it doesn't have signal void in T2 star. So even if it's a hematoma, we cannot rely on the T2 star to see that. But mainly, I think on the pattern of contrast enhancement. Another case will be a cystic meningioma, that there are some that are quite rare, but they can have quite a prominent subdural cystic component, like in this case, quite nice. But you see that the enhancement of the walls is very thin and quite incomplete. And as a meningioma, even if it's got a really big or large cystic component, it is always going to have a solid component. That's this one that is more caudal. So I think it may be quite easy to differentiate empyemas from subdural hematomas and cystic meningiomas. So if you have any questions, I'll be very happy to answer. So I'm all yours.
Thank you very much, Ines, for this excellent, presentation. There was question, but you've actually answered them on the way, and the questions were mostly in the use of, diffusion weighted to, differentiate between abscess and ring enhancing glioma, which I think, it's an important point. Question just come in. Should we include in the differential analysis of abscess high severity tumor with ADC restricted diffusion, such as glioblastoma multiforme or high-grade lymphoma?
Yes, because if the thing is that most of these tumors, they are slightly more irregular in margination than an abscess, and they may have a solid portion that help us to differentiate that from an abscess. But it may be that they are completely necrotic, and then they do look like an abscess. So these are the cases that definitely we do need to include neoplasia as a differential, and because it's a necrotic neoplasia, it's going to be a high grade, like glioblastoma multiforme or high grade lymphoma.
So to clarify, all the mature abscess will have restriction on ADC,
yes.
But some tumor will also have the similar. Yes. And you need to use other characteristic, and especially, the T2 hypoenthance rim, will be one of them. One thing, but I don't know if you rely on that, is the delay contrast enhancement, but you can see, the progressive contrast enhancement that you can see from the capsule in tumor, especially ring enhancing glioma, which you don't see really with the abscess. I mean, do you use in your MRI protocol? Do you routinely use a delay post contrast to see if there is this progressive, ring enhancement?
Normally, no. But I guess this will be interesting. But sometimes this is a bit challenging clinically wise, because a brain MRI is long, and if there are many patients, the clinicians and anesthetists are not super happy to wait more. So I think, and also it's not extremely well defined or well described how long we need to wait and how they look like, and if all are enhancing more afterward in the delay phase, yes or not, because I will think that also the abscess will enhance perhaps more. So yeah, I don't have any experience with that, but I think this will be very interesting. But it's a potential study to do, definitely.
To see if it make a difference, and also the type of enhancement, whether or not it's even or uneven as well. Because you will expect to be even with an abscess and not uneven with with a tumor. Can you just remind us what will be the differential in the T2 hypoenthance rim? What kind of we know abscess do that. You mentioned about hematoma. If there's any other condition that could cause this hypointense T2 rim.
I could think about abscess, hematoma, and maybe some tumors,
Okay.
but they are going to have an incomplete hypointense rim.
And do
So
we?
complete rim is only going to be an abscess and a hematoma.
Okay.
But as I said before, this is only going to be, they are only going to be similar on the T2.
Yeah.
But then if we look in the T1, in the T1 post contrast, in the even the flare, and definitely the T2 status susceptibility weighting, they are going to be completely different.
And we know the pathophysiology for the T2 hypointensity for the hematoma. We know that is related to hemosiderin deposition, and but do we know what is the cause for the abscess? What is the cellular basis for the hypointensity on T2?
I think it's I'm not very good at histopath. I need
I'm just wondering.
But I think it's because of the capsule is quite fibrotic and also rather neovascularized, and this is what this high cellularity is what is causing the hypointensity in T2.
Okay. Because it's
correlates this high cellularity with a slight hyperintensity in T1.
Because it's funny that we see it in these three, some tumor will have that, hematoma will have that, and obviously the abscesses. And they are all thin, they're not very big, and that's another thing. If you have any other question, we'll give you 10 seconds, so be quick at typing it, and then we'll release Ines for the evening. Simon, do you have any other question you wanted to ask?
I think the distinction you've made there to separate out those pathologies is excellent. Sometimes I will stumble on what a metastatic lesion should look like, because maybe they're a little bit more complete capsule, more smoother. So sometimes I'll struggle on trying to separate those out if they're solitary lesions. Do you have any advice on the metastasis versus abscess, particularly if it was a very necrotic or liquid-based metastasis?
In differentiating with an abscess or with a hematoma, you mean?
With an abscess, yeah.
With an abscess. They can look quite similar if they are completely necrotic. So that's why people, they normally rely on the diffusion ADC.
And do you use how much do you use edema in the separation of all of those things? The perilesional edema is
I don't think that is very useful, because both cause a horrible perilesional edema. Really, Mark, because both conditions are really aggressive to the brain. Because the neoplasias, if they are necrotic, as I said before, they are high grade. So they are really rapid growing masses that they cause a lot of edema and a lot of perilesional and a lot of mass effect as well.
Yeah. Last question from Tanya. Was the CSF helpful? I don't know if you remember, for this case, to confirm the final diagnosis.
I think they didn't take it because there was cerebellar herniation.
Yeah, absolutely. Oh, probably last one. I promise this one. The T2 star hypointense rim in abscess, I believe, can be caused by paramagnetic free radical within phagocytic macrophage reported in human.
Yeah. Definitely makes sense.
Thanks, Will, for that. We were wondering. Excellent. I think no more question. Tanya, say thank you. Thanks a lot, Ines, for this great presentation and for giving us your time to do that. We hope to do this kind of presentation regularly. I think, Simon, you can probably say what we're planning to do next year with the monthly you can explain the monthly.
Yeah, following on from our hallmark webinar series that we did recently, we're going to launch in January a journal club, once a month journal club. And so look out for the details of this. We're going to have a recently published paper and the author come on so that they can present the results of their research, how they put the study together, what was important about it. So take home messages for us all. We'll do it with a very similar format where we can ask questions, and you have the opportunity as well to ask questions about their study. So look out for this information coming up soon, that we'll get this started in January as another year rapidly approaches. Still being a little bit locked down, you'll all be looking forward to a monthly journal club session, something to do while you're at home.
But also, if you're about to have a neuroimaging paper being published, study, let us know, contact us, on Facebook, and we can look at, the possibility to have you presenting your paper. The aim is also to give, a platform for young radiologists, young neurologists, to put themselves on this, on this forum so that they can present their work and also interact with you. That's the main aim of this. Thank you very much, Ines. Thanks, Simon.
Thank you.
And,
Thanks, Ines. Really
Thank
appreciate
you.
it.
Thank you, everybody.
Thank you. Bye-bye.
Bye.
Bye.